my second lecture maybe end within 30 minutes, so take it easy. But in education, maybe you should raise your hand for correct answer. So maybe you have the printed version of my lecture, so there were no answer. So. Okay, let's start. So, case number 1. Chastity and epidepexity of 45 years old male female patient with a single pulmonary nodule. And what is most plausible diagnosis? So, you can see this nodule, lung setting, PET, CT, non-contrast CT, contrast CT. So, one is hematoma, 2 sclerotic hemangioma, carcinoid, minimal investigation carcinoma, 5 nuclear carcinoma. So now you can raise your hand for correct answer. So number 1 is the answer. Raise your hand. Then number 2, sclerotic hemangioma. So number 3, carcinoid. Number 4, minimal invasive adenocarcinoma. And number 5, mucoepithelial carcinoma. Okay, the size was 18 millimeters and maximum CV was 1.3. So correct answer is hematoma. So most of you can choose the right answer. Congratulations. So this is the typical capacity finding of hematoma of lung. So the most hematoma located peripherally and round, smooth, low-related margin. So sometimes you have a Parkinson calcification in 15 to 20%. And another characteristic is half of this tumor has the PET. PET means so you can see low house build unit on non-contrast CT. And another characteristic is very low accuracy optics, so no or faint optics. So those are the typical opacity finding of lung hematoma. So in this situation, it is not necessary to further invasive studies such as pathological confirmation. Just the regular clinical follow-up is necessary. Okay, to next place. Case number 2. Chastity and epidepexity of 47 years old female patient with pulmonary mass of left lobe. What is most plausible diagnosis? Number 1, organized pneumonia. Number 2, phyltoma. Number 3, carcinoid. Number 4, sclerotic hemangioma. Number 5, invasive carcinoma. So you can see the mass in this area. PET, fusion PET, non-contrast CT, and lung setting CT. Maximum SUV is 6.2. So now you can raise your hand. So the answer is number 1, organic pneumonia. Raise your hand. Oh, sorry. My mistake. So answer is question. It is some difficult question. So because organic pneumonia can show some calcification, but the different in the calcification pattern. So lung carcinoma has a typical location. It usually located at the lobar and segmental bronchi. This is the another different point between organic pneumonia, because organic pneumonia is occur irrespective of the bronchial anatomy. So the previous the opacity, you can see distal atelectasis. That is a key point, because distal atelectasis means the the mass locate within bronchial tree. I mean the endobronchial tumor. So this question is regarding the differential diagnosis between endobronchial tumor. So and another point is the 10 to 40% of this tumor located peripherally in some mucosa, endobronchial, around bronchial, and exobronchial. And another characteristic is the shape is polypoid, and as I told you, associated atelectasis. And calcification or ossification is found in 1/3 of the cases. So previously you can see the several focal calcification of this tumor. And the important is in terms of fat, the variable FPG uptake is found, usually moderate. So in carcinoid, it is very difficult to find very low FPG uptake. So you can find significant FPG uptake, but not high. So also the finding is some heterogeneous FPG uptake you can see, and with the moderate maximum SUV of 6.2. Okay, let's move to next case.
This is already.
Pardon?
This is already mentioned the MND before.
I know. So because maybe you can see this question of the pre-test maybe. So to help your solve the post-test evaluation. So I show this case. So this is the sclerosing hemangioma. So the chastity and capacity of it is all maturation nodal level. So you should know that this is not non-contrastivity. This is inercity. That means that this nodule has a significant enhancement similar to the adjacent major vessel. So this is an enhancing nodule. So you should know this is a contrast chastity. So sclerosing hemangioma is kind of benign vascular tumor. So rare benign tumor originated from a pneumocyte. So in chastity there was some typical findings. So solitary, well-defined nodular region, and importantly is significant inhomogeneous enhancement. So you can see the heterogeneous enhancement. And important thing is in terms of PET, moderate to high FPG uptake is found like this, the SC of 5.3. So you should know this significant uptake benign tumor of sclerosing hemangioma. Okay, let's move to next case. Case number 4, chastity and FPG capacity of 45 years old female patient with solitary pulmonary nodule. Choose your correct answer. So you see this, and this. Lung setting, contrast inelasticity. So at 1, it's a pure glandular nodule. Number 2, the possibility of non-mucinous adenocarcinoma is high. Number 3, there is no air bronchogram within the tumor. Number 4, the better pronounced than squamous cell carcinoma is the same stage. Based on PET-CT and chastity findings, it favors benign. So now raise your hand. Number 1, it's a pure glandular nodule. Number 2, possibility of non-mucinous adenocarcinoma high. And then number 3, there is no airflow within the tumor. Number 4, better pronounced than squamous carcinoma same stage. Number 5, based on PET-CT and chastity findings, it favors benign. Maybe it is some tough questions. So actually, the the answer is number 4. At first, you should know the CT findings of this nodule. This is the not pure solid nodule. You can see the air bronchogram within the tumor. That means it's not pure solid nodule. It's a subsolid or part-solid nodule. Then FG uptake is mild increased. So in this subsolid nodule with mild FG uptake, as I noted previously, typically we should consider the possibility of the adenocarcinoma, especially the mucinous or rapidly predominant and adenocarcinoma inside or minimally invasive carcinoma. So number one, it's not pure glandular nodule, the subsolid or part-solid nodule. So not non-mucinous, because air bronchogram is part-solid nodule. So mucinous adenocarcinoma, not non-mucinous carcinoma. So you can see the air bronchogram in the tumor. So post-specific finding, it favors malignant, not benign. And important thing is the low FG uptake and the part-solid nodule is the better prognosis than same stage of skin carcinoma. So in terms of prognosis, when surgically resected, usually the prognosis is good. So you can see the same slide picture previous lecture. So I skip slide. This case is some invasive mucinous adenocarcinoma, formerly mucinous PH. Now the adenocarcinoma, minimal invasive adenocarcinoma or invasive adenocarcinoma. So you can see the air bronchogram, major consolidation, the multifocal lymph presentation, and some kind of mutation is found. So according to this, the genotype mutation in advanced stage, molecular some targeted therapy can be done according to this type of mutation. And so same slide. A typical, as I told previously, that there are several kinds of new systems. This corresponds to the atypical hyperplasia and localized small creation of the mildly site. So usually less than 5 millimeters, so up to 12 meters. So when you see the capacity interpretation regarding pure glandular surface nodule, the less than 5 millimeters without uptake, pure GGO, then most probable diagnosis is the AH, typical hyperplasia. But even more than more than 5 millimeters and less than 30 millimeters, mostly pure glandular nodule, and mostly though sometimes mild FG uptake. The most probable diagnosis is adenocarcinoma in situ. So sometimes non-mucinous and or mucinous. So this is the typical finding of non-mucinous adenocarcinoma in situ. You can see the pure glandular surface nodule, and mucinous adenoma in situ. You can see the part solid nodule. So the difference between the typical CT findings. In case of minimally adenocarcinoma, so the size is usually more than 5 meters, but less than 30 meters. The imaging finding is less known because the very diverse capacity finding can be done, because sometimes pure glandular nodule, sometimes partial nodule, sometimes no uptake, sometimes the significant uptake. So it is very difficult to diagnose minimally invasive adenocarcinoma purely based on the capacity findings. And in case of typical invasive adenocarcinoma, the non-solid portion is decreased. So the most tumor consists of pure solid portion with high FG uptake. Then in this situation, you can definitely say, irrespective of size, invasive adenocarcinoma, not adenocarcinoma in situ. So mostly solid tumor with high uptake is considered invasive adenocarcinoma, not adenocarcinoma inside or minimally invasive adenocarcinoma. Okay, case number 5. Average capacity of a 57 years old female patient with lung adenocarcinoma. What is the correct capacity? Clinical T stage. Clinical T stage. This is based on 7th edition, not forthcoming 8th edition. So based on 7th edition. So you can see the primary tumor, another, take pattern. So number 1 is T1A, 2 T1B, number 3 T2A, number 4 T3, number 5 T4. Now raise your hand. The answer is number 1 T1A. Then answer is 2 T1B. Then answer is 3 T2A. And answer is for T3. Or answer is number 5 T4. Very few persons raise your hand. And the answer is 4 T3. So you should know the location of the fissure, because the fissure determine the lobe. Because in T staging the location of the tumor is very important. So you can, this is the major fissure. This is a major fissure. So that means this tumor located in the lingular segment of left upper lobe, and this nodules also in the lingular segment of left upper lobe. So in the same lobe, multiple hypermetabolic nodule. That means all those nodules are the malignant parenchymal lung tumors that corresponding to the T3. So you can see the T3, the separate multiple tumor nodules in the same lobe. So same lobe in the left upper lobe. So that means the T stage, clinical T stage is T3.
Pericardium was free in this case number 5. It is not attached to the pericardium. In that one, that slide.
Yeah, I know. So this mesh locates address to pericardium. So you know if the tumor invades the pericardium, stage is changed to T4. But you know the capacity, even the contrast CT cannot find the microscopic invasion of primary tumor to pericardium. So without definite invasion to pericardium on imaging, we cannot say the tumor invading to pericardium. So in this situation, you can see that is the pericardium, but the tumor is adjacent to pericardium, but there is no definite evidence gross invasion to the pericardium. So clinical stage is still T3, not T4. So the same patient, that means the same patient with the previous question. The same patient to previous case, what is the correct capacity, clinical, nodal, and distant metastasis stage? So you should focus on this region, this region, this region. So answer number 1 is N1M0. Answer number 2 is N2M0. Number 3 is N3M0. Number 4 is N0M1A. Number 5 is N0M1B. Then raise your hand according to your answer. So number 1, N1M0. Yeah, several people. Number 2, N2M0. Okay. Number 3, N3M0. Okay. Number 4, N0M1A. Okay. Number 5, N0M1B. Okay. Also, this is a very one of the tough questions. So answer is N0M1A. So the point is this hypermetabolic region is lymph node or not. And if the type of region is lymph node, what is the location? So if the hyper region is located to lymph node, the adjacent to aortic arch, that means not N1, N2 node. But if you see the PET image in detail, the shape of this hyper region is not the typical for lymph node. And another point is this soft tissue region is definitely the located along with the pleura. So this region is not the typical PET pattern for adjacent lymph node, but the pleura. So in case of pleural metastasis, the current based on current state system, that is the M1A, not N2. So this is the current the staging system. So tumor with pleural nodules or malignant pleural effusion is the M1A, not N2. Okay, let's move to next case. So maybe you already see the discussion, the pre-evaluation test. So efficacy of lung cancer patients, which node is metastatic? Number 1, this, and this finding.
It's the same.
Pardon?
Same. It is the same.
Yeah, same node.
What choices?
Same node.
What is the choice?
So wait, I move to next question. So this is the answer number 1. 2. This light particle load. This. So you should focus on the specific node, not the all hypermetabolic nodes. So this finding. Answer number 3, the paediatric lymph node, that means this. Okay, answer number 4, right lower part lymph node, that means this. Okay. Number 5, right lower part lymph node, this. So now, raise your hand. So answer is number 1. Okay, 1, 2 person. The answer is number 2. Okay. Answer is number 3. Okay, 1 person. Answer is number 4. Or several persons. Answer is number 5.
Yes. 4 or 5.
in this case, the
Maybe 4 because it's
yeah.
two things.
So answer is number 5. So let's review the case. So you can see the oops. In case number 1, you can see the high hypermetabolic sucker lymph node, but you can see the significant peripheral calcification. So as I told you previously, it is a benign lymph node, and you can see the diffuse high attenuation is radiographic lymph nodes. So even though it had a high uptake, so definitely diffuse high attenuation. That means the microscopic calcification or some relative change. So it is also the lithophility as benign. And you can see the parotid lymph node, although size is increased to 11 although there was no significant calcification or high attenuation, but the average uptake is very low, 1.9. So very essentially no uptake. So then in this case, then depends on the metastatic malignancy the decide based on pure average of degree of vector uptake. So it is benign. And on PER, so maybe it may be tough question because the CT finding is some difficult because you can see the high attenuation, linear high attenuation within the lymph node. So not peripherally, but within the linear high attenuation. So it is also the correspond to the significant high attenuation on lymph node. So it is also correspond to the benign lymph node, even though the lymph node has high uptake. So the question answer is now 5 because there was no definite high attenuation or calcification and high average uptake and enlarged size. So based on those criteria, this is a typical metastatic lymph node. So maybe I'll several slides. Okay, case number 8. Pre and post-operative, the post-operative is 2 years after operation. FG PET image of a 75 years old male patient with a squamous cell carcinoma of right upper lung. Choose a presence. So this is the pre-PET. So you can see the large hypoplastic mass on the right lower lung zone and the right hilar lymph node, maybe this subhilar lymph node. And post-operative, you can see the most uptake was disappeared. So, but the interesting point is not that side. So you should focus on this pre-operative PET image and post-operative PET image. So this also some of the top questions. So you should focus on the different PET findings in between two PET image sets. So now the example of answers. Number 1, immediate after curative surgery, advanced therapy is not necessary. Number 2, on follow-up PET, there is no evidence of metastasis. Answer number 3, based on follow-up PET findings, additional surgery is considered. Number 4, based on follow-up PET findings, additional radiotherapy is considered. Number 5, based on follow-up PET findings, additional chemotherapy is considered. So now I see you image again. This is MIP image, pre, post, also the pre, post. So this is the similar transition level, pre and post.
But it is not one.
Pardon?
It is not one window.
Yeah, not window because the point is not for long region. Yeah. Also, this is one of the tough questions.
On follow-up with CT, there is no distant metastasis. There is no metastasis.
So now it's a time for raise your hand. So
I think two.
The number one is correct. Raise your hand. Immediate therapeutic surgery, as therapy not necessary.
We don't know what's the primary disease. We don't know.
So,
Could be not
for your,
oh, this one, yes.
yeah. Squamous carcinoma of right upper.
No, it's necessary. I mean, adjuvant. We should give adjuvant treatment because it's big tumor.
Yeah, that's a primary tumor. Yeah.
So this the first is wrong.
Okay. Raise your hand if the correct answer is number 2. On follow-up CT, there is no evidence of metastasis.
Yeah, I think yes.
Okay. Okay, number 3. Based on follow-up step, additional surgery considered. And number 4, additional radiotherapy listeners. Number 5, additional chemotherapy considered.
Yes, I think it's true also.
Yeah. So,
2 and 5. We'll go
okay,
more with 5.
yeah, answer is 5. So, in this case, the point, because in this case, as you can see, the antinode is positive, so in case the adjuvant chemotherapy or chemoradiotherapy necessary according to the HCN guidelines, so number 1 is not correct. And in follow-up CT, there's no evidence. So this is the somewhat tough interpretation because so on follow-up PET-CT, you should focus on this area and compare with the previous PET-CT. So although the image quality is not good, so you can see the peritoneal thickening and association to small peritoneal nodules. And this is the PET image with the high lowering upper threshold. You can see this area, so mild uptake is found in these areas. That means that the very unusual case of small size of peritoneal metastasis. So when you see the PET image alone, it is very, very difficult to find this metastasis. So the point is you should carefully see the CT images, especially for small lesions. As I told previously, the small pleural or peritoneal lesions, due to partial volume effect, the average uptake is very low, so we can miss those kind of new small lesions. So we should carefully review the whole PET, whole CT or PET images. Yeah. Pardon?
Do you assume it's metastasis
Hmm?
even without biopsy?
Although also in this situation we cannot definitely say this kind of region is metastatic, but we should suggest the possibility of metastasis. So to draw a further evaluation or careful clinical follow-up. So because some benign peritoneal, non-specific peritoneal thickening or non-peritoneal nodular region can occur without evidence of malignancy. So although we cannot say definitely the region is metastatic, but we should raise the possibility of metastatic region to the further evaluation of careful clinical follow-up. So in this situation, if so that's the reason I expressed the question considered not definitely necessary, because in this situation the further evidence for peritoneal metastasis is necessary. So the clinician ordered the follow-up abdominal CT. So you can see the on follow-up CT imaging, definitely the peritoneal seeding regions on abdominal CT. So the additional chemotherapy is performed. So case number 9. After PET images of a 45 years old male patient with squamous cell carcinoma of right upper shows a sentence. So you can see the lung primary tumor, mediastinal lymph nodes metastasis, and the point is this. So possible answer number 1, appropriate initial therapy is surgery. Number 2, distant metastasis in left nose is suspected. Number 3, benign inflammatory lesion is suspected in left nose. Number 4, second primary cancer in left nose is suspected. Number 5, pathological confirmation for left nose lesion is not necessary. Okay, now raise your hand. So number 1 is answer. Initial therapy surgery.
Beyond surgery.
Okay, number 2, distant metastasis in left nose is suspected. Number 3, benign inflammatory lesion is suspected in left nose.
Yes,
3.
could be.
Number 4, second primary cancer left nose is suspected. Okay, now 5, pathological confirmation for left nose is not necessary.
False.
Okay, the correct answer is number 4. Because you can see definitely the high metabolic burden on mediastinal lymph nodes. You can so in case like this, if in lung cancer, if the patient has that kind of the huge amount of metastatic tumor burden on mediastinal lymph nodes, initial therapy is not surgery. So the current therapy is the concurrent chemoradiation therapy or neoadjuvant therapy followed by surgery, not initial therapy is surgery. And the issue is the left nose region. So you should know the nose is not a typical metastasite for lung cancer. So lung cancer in lung cancer hematogenous metastasis, usually the common metastasite is the organs where the blood flow is evident. So nose is not a typical organ for high blood flow. So nose is not a typical site for metastasis. So the next step is that means that this region is malignant, second prime malignant or inflammatory. So in this case, we should focusing on the CT image. So most common inflammatory region in nose is the skin region. So you can see the nose region is corresponding skin or not. So you see this CT image. The region within the left nose and the protruding into the nasal cavity. That means the main focus is not the epicenter of this region is not skin. Within the dermis or the center of the test region. So in this situation, the first impression is not inflammatory region. So we should raise the possibility of second primary cancer. So this is one of the previous studies in lung cancer. The patient also useful for detect clinically undetected second primary cancer with metastasis. So although the second primary cancer is not the common situation clinically, but one of the advantages of PET is the whole body imaging. So there are many original or case reports regarding the usefulness of FG PET to detect second primary cancer. So I'll introduce several terms. So in second primary cancer evaluation, so sometimes the second primary cancer, double primary cancer, second primary is used the combined list. So index tumor is the original tumor. And there are 3 kinds of second primary tumor. One is synchronous second primary cancer, metachronous, simultaneous. So it depends on the time sequence between primary tumor and second primary tumor. If second primary tumor was found within 6 months from primary tumor, in situation that tumor second primary cancer is synchronous. Second primary tumor was found more than 6 months after primary cancer, then that kind of second primary cancer is called metachronous. As a subtype of synchronous second primary cancer, second primary cancer is detected within 1 month after previous primary cancer. Then means that in this situation, the second primary tumor was simultaneous primary tumor. So that is the common terms for second primary cancer. It may be helpful to understand the second primary cancer. So now case number 10. Pre and post chemotherapy CT images of 60 years old male patient with adenocarcinoma of right lobe. Choose a correct response based on RECIST. So I'll talk briefly RECIST. So tumor is located at right lobe. So baseline tumor size was 35 millimeters, and follow-up after chemotherapy tumor size was 9.0 millimeter. So answer number 1 is complete response, partial response, stable disease, progress disease, indeterminate. So raise your hand if the correct answer is number 1, CR. Okay. Raise your hand. Number 2 is partial. And number 3 is stable. Number 4, proceed. Now 5, indeterminate. Okay. So correct answer is partial response. So as I told you, the change in the tumor diameter is the more than 30% decrease. So there is a partial response. But in this situation, this response criteria is applied for target lesion of especially the primary tumor. If the lesion was metastatic lymph node, size was 35 meter to 9 millimeters, then not primary then lesion corresponds to the metastatic lymph node, then lymph node response is not PR, CR. Because on RECIST, in case of lymph node, the lymph node size should be more than 10 millimeters. So on follow-up follow-up image, if size was less than 10 millimeters, that means within normal size limit. So even if the lymph node is visible, but response is CR, not PR. So you should know the different response criteria between primary tumor and metastatic lymph node. Also, you should know the different response criteria between target lesion and non-target lesion based on RECIST. And case number 11. Pre and post chemotherapy capacity image of 66 years old male patient with adenocarcinoma lobe. Choose a correct metabolism. That means the same patient. So you say maximum SUV 4.1, average 20.7, metabolic tumor volume 8 to 8. So this 50% means the cutoff SUV. That means the 50% of maximum SUV was used for tumor cells only. This is the baseline value. So you should know the follow-up path. Maximum SUV is 1.2, average SUV is 1.1, metabolic volume. So within this thresholding, the tumor was not defined. So the follow-up case is the tumor threshold SUV was 90% of maximum SUV, then 0.6. You can see this. So correct metabolic response is number 1 is CR, number 2 is PR, 3 SD, 4 PD, 5 indeterminate. So now raise your hand. The correct answer is CR. Okay. Many persons raise your hand. CR. Number 2 PR. Okay. Number 3 SD. Number 4 PD. Number 5 independent. Good, very good. So answer is CR. Because even the tumor was visible faintly, but you know that this uptake is less than mediastinal proof. That means the low uptake less than background the area. So that means the indiscernible uptake from background that corresponds to the complete metabolic response. So in this case, the typical case for the metabolic CR. Now, case number 2, case number 12. Pre and post chemotherapy CT image of a 58 years old male patient with adenocarcinoma of right upper lung. Choose a correct response based on RECIST. So you can see the focus on this area. Chodex diameter is 8.9 mm baseline. Chodex diameter 36 mm on follow. So answer number one is CR, 2 PR, 3 SD, 4 PD, or 5 indeterminate. So now raise your hand. Correct answer is CR. Okay. 2 PR, 4 SD, or 4 PD, 5 indeterminate. Okay, good. So answer is PD because there was no abnormality in left adrenal gland on this area, but the follow-up CT, you can say enlarged mass on left adrenal gland, so definitely is a PD. But important difference is the follow-up pad. At baseline, this is not target because you can see this CT image, left adrenal gland is nearly normal, not tumorism. So move to the same patient PET image. Pre and post chemotherapy chest image of 58 years old, male patient with the same patient. You can see the same region. Maximum SUV 7.8, average SUV 5.2, MTB 1.3, and follow-up maximum SUV 7.3, average 4.5, MTB 50% cut off, 5.2 cubic centimeter. So answer is 1 CR, 2 PR, 3 SD, 4 PD, 5 indeterminate. So raise your hand if the case answer is CR, PR, SD, PD, indeterminate. Okay, good. So answer is PD. But in this case, you should know the different change in PET metabolic parameters. So you know in case of maximum SUV and average SUV, there was no significant changes. So if you decide the metabolic response based on this kind of image, so this is not good. That means this response evaluation based on maximum SUV and average SUV is not applicable in this case, not generally. In this case, not. So considering all situation, in this case, the appropriate PET parameter for response evaluation is metabolic tumor volume. The pre-baseline metabolic was 1.2, but significantly increased to 5.2. So that means progressive disease based on metabolic tumor volume, not maximum SUV or average SUV. So that is the point. And another point is, as I told you previously, based on previous CT, left adrenal gland is not target lesion because there are several famous reports to detect left adrenal gland metastasis. PET is more sensitive to CT. So that is another special case. So based on baseline PET, adrenal gland is although size is within normal rates, but very high uptake. So in this case, we should raise the possibility of left adrenal gland metastasis. So in baseline, left adrenal gland is included as a target lesion. So there's a difference between anti CT and the functional PET image. Okay. So this is my last case. Any questions or comments?
I can see the